Hello, my name is Dr. Manuel Cerquera, and I'm chairman of nuclear medicine and a staff cardiologist at the Cleveland Clinic, and I'm here with my colleague.
I'm Aldo Scanoni. I'm one of the current fellows at the Cleveland Clinic.
He's one of our top fellows, and today we're going to be talking about the evaluation of a symptomatic patient with ischemic cardiomyopathy, the advantages of PET imaging in this situation. So, Aldo, why don't you present the case that we have prepared?
Absolutely. So it is my pleasure to present this case, which was a 64-year-old man with a history of ischemic cardiomyopathy, who initially had some PCI to the LAD and the RCA, but eventually ended up with bypass surgery with Lima graft to the LAD, venous graft to the circumflex, and venous graft to the RCA, who most recently clinical course was complicated by a non-ST elevation MI, at which time a coronary angiogram was obtained, which revealed a new occlusion of both venous graft, one to the, as we said, to the circumflex and one to the RCA, but in presence of a patent Lima to LAD. So at that point, the decision was made to treat medically with close clinical follow-up. The patient comes back and complains of persistent anginal symptoms and a decreased functional capacity, all despite obtubration and optimization of medical management. At that point in time, a resting echocardiogram was obtained, which revealed a sinus rhythm with a normal axis with the evidence of a few ischemic changes that I'm going to point out. So the first being the presence of lateral horizontal ST depressions with associated T-wave inversions. And second, we can see that there is suggestion of a remote transmural inferior myocardial infarction given the presence of Q-wave in inferior leads with associated ST elevations. And they're kind of highlighted also in the circles. So at that point, the decision was made to proceed with a PET myocardial perfusion and viability study to try to determine what are the potential benefits of revascularizing this patient. So in this slide, we present the protocol that we follow in our institution for perfusion and viability. In this patient, regadenoson was used as a stress agent. And shortly after the injection of regadenoson, the patient reported onset of chest pain, which was similar to the pain and symptoms he was experiencing over the last few weeks. But no ischemic changes were seen in the ECG. For the viability part, his glucose was checked initially, and he received 25 grams of dextrose 50%, after which he got 2 units of regular insulin for a glucose of 154, and the FDG images were obtained 1 hour later. So here we present the images or the results of both the perfusion and the viability study. So in the top panel, we present first the stress images, followed by the rest images in between, and the viability of FDG images at the bottom. We also present the polar maps beneath that for an easier interpretation and identification of the findings. So when we look into this study, there are 3 important findings that deserve mention and discussion. So the first thing is, in the area that has been highlighted with this kind of white outline for you, we see that there is evidence of a mild reversible perfusion defect consistent with mild ischemia that involves predominantly the circ and the RCA territory, but also has a little bit of ischemia in the LAD territory, so it's kind of mild ischemia in all territories. But what is more notable as a second finding is that if you focus on the resting images, there is a large fixed perfusion defect in that territory that is matched perfectly with a high uptake of FDG in that area, which again is consistent with the presence of hibernating myocardium predominantly without any evidence of scar or infarcted myocardium. And this has important prognostic and therapeutic implications, given that these patients usually have worse prognosis and also might benefit from revascularization. I think it's important for this case. Lastly, I think it's important to mention that when you look into the qualitative and quantitative assessment of this study, there's evidence of dilatation of the LV cavity with stress. And at the bottom of the slide, we can see that the measured TID ratio was 1.27, which is consistent with the transient ischemic dilatation, which has important prognostic, utility. So now, moving towards the gated images, I think it's important to see that or draw the attention to that circumflex and RCA territory, which we can see that there's a more prominent wall motion abnormality, which is not unexpected, given that those territory have a large degree of hibernating myocardium and some degree of ischemia, and which lose some of the contractile reserve. It's also important to mention that if we pay attention to the ejection fraction, in this patient, resting ejection fraction of 39% went down to 26% with stress. And also, we see that the end systolic volume is elevated at 120 milliliters, which again has bad prognosis implications in this patient. So I think it's important to recognize that some of these decreases in the ejection fraction respond to the large area of hibernating myocardium that, again, when is challenged with stress, is not able to respond and actually might become ischemic. And as a consequence, you have a drop in the ejection fraction, suggesting ischemia. But also in this type of patient, sometimes we have the presence of microvascular disease that again can compromise the flow to the myocardium and result in further decrease in the ejection fraction. So I think in conclusion, we will review some of the findings, and we're going to focus here in kind of the final result of the study, which was read as a high-risk scan on the basis of the mild ischemia that we saw, but more so based on the large degree of hibernating myocardium with a drop in the F with stress and the presence of transient ischemic dilatation. So given the patient's symptoms and based on in response to the findings of hibernation and ischemic myocardium, which we can call myocardial at risk, the patient was referred for redo bypass surgery, for which he obtained a RIMA to the circumflex and a SVG or a venous graft to the RCA. His operative course was free of complication, but more importantly, on the following months, he reported an improvement and resolution of his anginal symptoms with an associated improvement in functional capacity. An echocardiogram was obtained at that point, which revealed, importantly, internal improvement on the LV ejection fraction from 30% initially before revascularization to 50%.
Excellent job. So, again, here we've demonstrated that PET can provide you a measure of ischemia, which in this case was not very large, but equally as important, the ability to identify hibernation to predict good outcomes. So this is our first question. Which of the following statements is false comparing SPECT and PET? So Aldo, do you want to comment on each of the category options that are here?
Yeah, absolutely. I think we can go one by one and just try to identify which statement is false. In option A, it says that SPECT diagnostic accuracy compared to PET is limited in part due to higher proportion of artifact. And this is a true statement. So we know that SPECT is limited first by lower spatial resolution compared to PET. Usually has more artifacts derived from GI uptake. The images acquisitions are usually has more time between the stress and the image acquisition for SPECT rather than PET, all which limit the accuracy or the diagnostic accuracy of SPECT. So this is a true statement here.
So the advantage of PET is that you have shorter acquisitions, less motion. Rubidium itself predominantly goes to the heart. You don't get the GI or the liver retention that many times cause cause artifact, and it has higher spatial resolution. You get attenuation correction routinely with PET. You also get scatter correction with PET, and these are advantages over the use of PET.
Correct. So now when we move to option B, and it says that PET is inferior to SPECT in localizing disease to a single coronary territory or a single coronary territories. This is a false statement. PET having the higher resolution, the shorter acquisition times, the less amount or proportion of artifacts, in fact, allows you to localize better disease to a single territory. So this is the right answer.
Very good. And then again, if anything, PET is able to identify multi-vessel disease better. It works well in people who have balanced disease, especially when you add attenuation correction and you add flow reserve that we're not going to be talking about in this session. So clearly, PET is superior in all of these categories to SPECT.
Correct. And then if we move to the option C and D, I think we talk about this particular statement a little bit in the prior, answers. So the ECG-gated PET is more likely to detect ischemic wall motions, just by the sole reason that the image sensitivity are shorter, and you're able to be closer to that stressed compared to SPECT. And option D, I think. And we talk about this. PET has higher counts that are recorded, and that improves, along with other things, the spatial resolution of the study in comparison to SPECT.
Yeah, very, very good points. If we go back to C for just a minute, one of the disadvantages of PET in this situation is that with rubidium you cannot do dynamic exercise, so you're limited to pharmacologic stress. But once you induce the stress with a vasodilator, you have really about 1.5 to 2 minutes before you start the image acquisition with PET, whereas with SPECT, the separation is at least 10 minutes and usually longer, especially when you're doing pharmacologic stress. And so if you have any induced wall motion abnormalities because of the ischemia that's induced, the separation between the stress and the imaging may allow those wall motion abnormalities to go away. As you saw here with this patient, the ejection fraction dropped significantly, indicating that there was wall motion that we were able to capture more accurately with the use of PET because of the shorter separation between between stress and acquisition. Great. Why don't you go on to the next question? In patients with ischemic LV dysfunction, which of the following is true in terms of PET viability testing and outcomes? And these are the 4 possible options. So why don't you walk us through the 4 options?
Absolutely. So option A tells us that the presence of viability on PET is associated with improved outcomes in patients with ischemic LV dysfunction, which is, I think, is false. Usually these patients are, have an associated worse outcomes by definition. There's few studies have been, proven this point. So this is false. So it's not the right answer. Moving to option B, revascularization in the setting of high burden, more than 10% of myocardial hibernation, is associated with improved outcomes. And I think this kind of answer relates to our case. So it is known, it has been proven in studies that when you have high degree of hibernating myocardium, these are the patients who actually benefit in terms of cardiovascular outcomes. And we see, and we saw in this patient that not only in outcomes, but also can get benefit in terms of symptoms and functional capacity and ejection fraction. So this is the right answer here. Now, if we move to option C, only those patients with viability on PET who had an improvement in ejection fraction are the ones who get improved outcomes. And this is false. Even though we would like to get to see that the patients, all our patients who we revascularize, once we identify hibernation, we would like them to kind of have an improvement in ejection fraction. Not all of them get that benefit. But what is important here to mention is that if you revascularize this patient, regardless of the ejection fraction recovery, they all get the benefit on outcome.
Just a comment here. I mean, if you're going to get improvements in ejection fraction, does it occur like the week after surgery? What's the time course for recovery?
So I think when you think about hibernation, there's a lot of changes that has happened in that cell. So that cell needs to kind of change all the machinery, the DNA and level and everything to switch metabolism. So I wouldn't expect any immediate change in function in the next week or so. So you need to kind of do all these changes from a DNA and metabolism perspective to really get the benefit of revascularization. So I would say that at least a few months in order to kind of assess what's going to be the benefit of the intervention.
If not longer, in the sense that some of those biochemical changes, but clearly there's probably changes in volume that occur over time that may improve contractility. But you're right. Even if the EF doesn't improve, if there's viability, people tend to have improved outcomes, and that's an important point. And now D.
So the final statement here is that differentiating between normal ischemic hibernating and scar myocardium has no prognostic utility. And I think we already touched a little bit on that. And I think it's important to differentiate between these because first, we know that those with ischemic or hibernating myocardium might have worse outcomes compared, for instance, to normal. And they also have therapeutic utility in terms of determining or helping the physician guide revascularization. So I think it's important, and that's one of the advantages of PET in these days, that you can really differentiate what is normal, what is scar myocardium, and what we like to call what is the myocardium at risk, which is a combination of ischemic and hibernating myocardium, which allows you to understand the prognostic of this patient moving forward.
Very good. So I think, again, this is a very important area. One of the limitations in all of this, everything you can identify about ischemia, about hibernation, it's dependent on the surgical results. And many times, if you've got good targets, you can get good outcomes. But if you've got sort of diffuse disease or the residual vessels are so small, and in this case, you may not even be able to see the RCA and the LCX because the grafts have been occluded. So how do you determine who's going to benefit because they've got good targets or not?
Yeah, so I think when you are looking or assessing this patient, I think, and you have a PET with perfusion and viability, I think there's two things that you need to look for. I think the first thing is how likely, from an study perspective, this patient is going to benefit. And I think if you have a high burden of hibernating myocardium, and I think the cutoff that's been defined in prior studies, not that there's any magical aspect to that particular cutoff, but it has been described that when you have more than 10% of hibernating myocardium, the vascularization would provide benefit in terms of outcomes. So
right, provided you can get to target.
Correct.
That's still the
correct. And that's the second thing. I think one thing is the study result, but also is what's the feasibility of providing a good revascularization to that territory, and you're looking into how feasible it is to get the graft there, and also how are the vessels past the bypass, and they're able to provide a good flow to the myocardium.
Very, very good point. So, in summary, these are the teaching points. Do you want to go over them? We've identified many of them.
Yeah, I think we can summarize saying that PET is a study that provides a higher diagnostic accuracy with an improved certainty in terms of interpretation of the results when compared to SPECT. And this is as a result of improved spatial resolution, increased amount of artifacts, the ability of a more consistent attenuation correction, and shorter image acquisition times from stress to acquisition. I think the second point is that the PET allows you to differentiate between normal ischemic, hibernating, and scarred myocardium, and that can help you guide your therapy with evidence supporting improved outcomes when you revascularize the patient with a high degree of myocardial risk, which basically is a patient who has either a high amount of ischemia or high amount of hibernating myocardium. And I think one thing that is important to mention, I think the benefit of revascularization in these patients occur despite improvement of EF, but also we can kind of guess how likely this patient is going to recover EF based on the magnitude of viability.
Very good. And again, this is one of the unique things about PET is that we can use the FDG to identify the hibernation. With SPECT, we don't have any agents for hibernation that can be labeled with single photon agents. So thank you very much for this excellent case presentation and discussion, and we'll end here.